Thanks for everyone for coming today. I'm Grace Lee. I'm a physiatrist that's working here and other adult hospitals as well. I'm Kate Wortley. I'm also a physiatrist and I work exclusively here at Children's. So we wanted to talk today about pediatric disorders of consciousness, or DOC, we'll abbreviate as. So briefly, we're going to give some background on what disorders of consciousness is, and then provide a kind of potential model for Sunny Hill to adopt around how we should be treating people with DOC. So some resources that are freely available and excellent and evidence-based are these resources here. And these are the 2018 guidelines for management of disorders of consciousness. So we often reference this as well. These are for adults, but many we extrapolate for children. So first I wanted to talk about a case that many of you guys might remember. So back in 2019 at the old Sunny Hill, we had 2 patients who came in at roughly the same time. The person on your left is Annie, who 12-year-old who was in a ATV rollover accident, and quite specifically, they remember because her cousin was in the car at the time that she was talking initially after this accident, and then the weight of the ATV on her chest caused her to turn blue, and she became unresponsive after that. And she wasn't wearing a helmet at the time, and they were in a faraway place and took some time to get her to the hospital. The other person, also a 12-year-old, she had some horse injury. Wasn't totally clear what happened, but some horse-related injury. And she was wearing a helmet, and she immediately became unresponsive after this horse injury. And so these are the initial images for these girls that the person on your left, nothing too obvious to the untrained eye other than there's edema. You don't see the little gyrations as well. And that gray-white distinguishment, you can't quite see as clearly. On the left, there's a big hole or whiteness in the middle, which represents some bleeding and different spots of bleeding. So these are just representative images. And then lower down, you also see kind of similarly that not much to see on the left, but actually this represents what DAI, diffuse axonal injury, looks like. And on the other side, again, more spots of white, which represents bleeding. So for Annie, she was given a poor prognosis, and so the family made the decision to withdraw the ventilator at 1 week after injury. But amazingly, she started to breathe on her own, and so regular care kind of continued at that point. For the other girl, she had high pressures, so they put in an ICP monitor, did hypertonic saline, tried to maintain her blood pressures and cooled her, which is interesting, but won't talk too much about that. So both girls came to Sunny Hill roughly 1 month after their injury, and both were in a very similar condition at the time. They had eyes open, they couldn't fix, their eyes wouldn't fix on anything. Annie on the left had really tight elbow flexors, and Chloe had a lot of arching movements. And so both were very similar. And what happened at the end, Annie was discharged from Sunny Hill after about 4 months stay. She remained very similar to the admission level of consciousness. So she continued to need everything. So like peg tube feeds, Foley catheter. She continued to be very tight throughout. Whereas Chloe, she was discharged around March, which was about 6 months. She was discharged probably like a bit earlier than what we would have because it was early COVID and no one really wanted to be in the hospital at the time. And so by the time she left, she was able to walk with a four-wheel walker and walk even without anything at times, short distances, could follow commands, and was starting to eat by mouth. And so both of these girls, it's now about 5 years later. Annie is about the same, and Chloe is not 100% normal, but able to walk, participate in high school, and kind of very much better outcome than Chloe. So much better outcome than the girl on the left. So I guess after that, there was this thought around like, could we have known early on who would have been the one to make some improvements and who would have been the one to make less improvements, and maybe this has some effects on like the family unit being in the hospital for so long, our own resource management, and like outcomes of people. And also like what do other places do for people with DOC? So those were some questions. And so that's kind of where we're framing our presentation of like, we want to learn more about what to do.
Yeah. So this is definitely an area that's pretty terminology heavy. So we figured we'd go through a little bit of it, starting with, what is consciousness? And I am no philosopher, so there's various philosophical definitions, but I think for our purposes, simply put, there's two major components of consciousness we consider: the level of consciousness, which you'll probably see us here and talk about as arousal or wakefulness, and the content of consciousness, which is awareness or experience. And so essentially both arousal and awareness are required to be in a conscious state. When we consider wakefulness from a physiology perspective, it's the normal functioning or typical functioning between the reticular activating system within the brainstem, projecting through the thalamus to the bilateral cerebral cortex. So this is kind of an interesting slide because you can see in purple is kind of how we typically think of consciousness and probably how we all experience consciousness on a day-to-day. So usually we have a linear increase in both awareness and wakefulness. So you can see you kind of start in deep sleep, you'll go to light sleep, and then eventually we all wake up, maybe not so happily in the morning, but that's separate. In disorders of consciousness, this is dissociated. So essentially, you get an imbalance between the components of consciousness, which we can look at quantitatively when we're looking at wakefulness level, or qualitatively when we're thinking about self or environmental awareness. Disorders of consciousness, as you've kind of seen in our cases, results from injury to the cerebral cortex, thalamus, and reticular activating system. It's a hard word for the morning. So you also might hear us talk about prolonged disorders of consciousness with the literature. So just to define that, it's essentially absence of or limited signs of consciousness for at least 4 weeks after acute brain injury. So that will include the unresponsive wakefulness state and minimally conscious state that we'll talk about. So this is a bit of a busy slide, but kind of puts it all on one. So we'll go through each of them individually. So we have coma, vegetative state or unresponsive wakefulness state, and then minimally conscious state. Starting at coma, so essentially a state of persistent and deep pathological unconsciousness. So how does this look clinically? They're not awake or aware. The eyes will remain continuously closed despite any sort of noxious stimuli. There will be no sleep-wake cycles typically seen on EEG, no spontaneous purposeful movement, inability to localize to noxious stimuli, and no evidence of language comprehension or expression. And typically coma is diagnosed lasting longer than 1 hour, up to 4 weeks. When we think of unresponsive wakefulness state and vegetative state, we flip-flop between the two because you'll probably come across both terms in various literature. Vegetative state is kind of the more long-standing term, but as you can imagine, there's kind of some things that come along with that terminology that can be a little bit more challenging for families to hear. So the European Task Force in 2009 introduced this unresponsive wakefulness state. It's not globally accepted, so you'll probably still hear both terminology. So essentially, moving to this UWS state, if you will, the loss of capacity to interact with the environment, so that awareness piece, despite the preserved potential for spontaneous or stimulus-induced arousal. So how does that differ clinically? Eyes are now open, so that can open spontaneously or with noxious stimuli. And we do get intermittent wakefulness with sleep-wake cycles. So those might not look normal or typical, but we do get kind of cycling. You still don't have any evidence of purposeful behavior. You may see kind of startle reflex responses, but not purposeful movement, and no evidence of any intelligible verbal or gestural communication has been developed. Once we see those eyes open, as Grace was highlighting, we start to look for that tracking piece. And that's because visual tracking is a good sign of a patient transitioning out of the unresponsive wakefulness state. And worth noting in our little ones, obviously due to their differences in sleep-wake cycles and social emotional responses, it can be a little difficult to determine that. We've subcategorized this into persistent UWS, so longer than 1 month, and permanent UWS, longer than 6 months after non-traumatic and 12 months after traumatic injury. However, this was redefined in 2013 into chronic UWS. However, you can still reclassify it to permanent. So again, you might see interchanging terminology. And then moving up to the last level of minimally conscious state. So this is actually kind of the newest of the terms. So it was kind of introduced 2002. So any prior literature doesn't really reference this term, but it does reference these types of clinical features. So essentially a severely altered consciousness with minimal but definite behavioral evidence of self or environmental awareness. So now we have arousal and awareness. And we're looking for reproducible and sustained evidence of one or more of the following. So following commands, simple commands, gestural or verbal yes, no responses, regardless of accuracy, intelligible speech and movements or affective behaviors occurring in contingent relation to relevant environmental stimuli rather than reflex activity. So all that means is essentially if you give a photo of their family member and they smile versus a photo of kind of any regular thing and there's no smile, that would be a kind of an appropriate affective response you'd be looking for. And worth noting that reproducible and sustained, but it doesn't have to be consistent. So it can still be inconsistent. And again, when we're looking at our younger kids, this is challenging due to kind of pre-morbid language skill development. So this has been further separated because we need more terms into minimally conscious plus and minimally conscious minus, and then emergence from MCS. So minimally conscious minus is kind of the more simple things that we see. So visual fixation and pursuit, automatic motor reactions like scratching or pulling at the bed sheet or localization. And minimally conscious plus is essentially all of the above and following of simple commands, intelligible verbalization, or intentional communication. So kind of more complex things that we're seeing. And when we look into emergence from minimally conscious state, this is a big thing that we look for in terms of kind of emerge from disorders of consciousness. So the criteria require consistent demonstration of one or both. So use of interactive functional communication. So essentially testing wise, this looks like answering correctly in 6 out of the 6 basic situational orientation questions in 2 different assessments, or functional use of 2 different objects that are age appropriate typically. So this is just a summary slide where we put some references if anyone wants to read further into that. And then one of the things we obviously look at when we're trying to classify all of those things is our practice guideline essentially recommends doing diagnostic assessments and using valid standardized tools to do that, which all these lovely people in the room potentially know about. So we have a few we'll touch on here. The JFK Coma Recovery Scale revised is essentially the gold standard in adult assessment of DOC, where we pull from those guidelines, but has been employed in a number of studies to diagnose DOC states in children over the age of 5. Typically, this is administered at least 5 times, and children get assigned the highest or most optimistic response as their level of consciousness. And when we compare this to another one, the Coma Near Coma scale, which I'll talk about, it tends to define states better, but is still impacted by motor impairment aspect of the classification. And then there's a pediatric version for children aged 1 to 5 because it takes into account the language differences. So it looks like this, busy slide, I know, but for people who may or may not have seen it. And then coma near coma, or the Rappaport, might also be one you're familiar with. Essentially similar to JFK, although slightly different. It does do a slightly better job of discriminating changes in the lower functioning states. However, because this measure is older, essentially coma near coma are not terms that I just went through, the levels of functioning don't really respond to current terminology, and that can be challenging. And this one isn't necessarily a standardized assessment per se, but one you might come across or hear us use in the hospital, the Rancho Los Amigos. So essentially levels 1, 2, and 3 are what we're looking at in the DOC states, but then this also kind of shows the other stages that we look at as we kind of emerge from disorders of consciousness.
And so looking into what treatments we have, both pharmacologic and non, cooling is one of those things that very specifically in this situation. Actually, there's been a recent update, 2023. It used to be since 2002, it was recommended to do therapeutic cooling, and now there's a little bit of debate if we should just keep them at their normal temperature and prevent fever versus cooling for adults. And for children, also similar around should we actually cool them or just prevent fever? But that is something that is one of the things that we had been using very specifically for cardiac arrest patients who were comatose. And this was found to improve their survival, but some more recent papers found like less effect. And so that's why the guidelines have been changed. There's some obvious things that we need to do, but this is why children need to be in specialized centers or people with DOC to know what we're looking for or common complications, and obviously work to prevent these from happening. And in general, something that we always remind everyone is that patients might or can hear you. And we've had many patients tell us after the fact that they heard everything that we said, told us things that we said to them that they wouldn't have otherwise known. So remind everyone that they can hear you, likely. So to be careful of what you say and with them in the room. And some complications that are common or severe. The severe ones are this paroxysmal sympathetic hyperactivity, which we see especially in children and young adults, these like sympathetic storms or things like this that can be very challenging to manage, sometimes requiring ICU stay. So also PNA is pneumonia and hydrocephalus. These are things that we really have to watch out for because they can have very negative effects. In terms of medications, there's one medication that has the most evidence for, which is amantadine. Amantadine is like a dopamine agent, and there was a New England study done, which essentially was done on 16 children or people age 16 and up, and they started amantadine 4 weeks to 16 weeks after injury, and they gave them a dose starting at 100 twice a day and would increase if they were not having increase in level of consciousness. And so this study did show that people seem to emerge from their lower level of consciousness quicker with being on this medication, although there are some contraindications, relative contraindications to these medications, especially seizure disorder is probably the most relevant for people who have just had a brain injury. That might be a problem if they have had or are having uncontrolled seizures. There's a slew of other medications. I'd say more recently, the Kennedy Krieger Rehab Hospital, they were suggesting Sinemet might work better in children. We haven't tried that too much, but we do use methylphenidate quite a bit here as well. and limited or no evidence for other variety of things. And the most commonly that we're asked about is hyperbaric oxygen. On the one hand, it's very difficult to get some of these patients into that because there's so many lines and different things, but also that there's not really evidence for it other than carbon monoxide poisoning in that initial first few days. So getting to the more interesting part is the prognostication of, are there things that we should be looking for to help us have some sense of whether the person is going to improve or not improve? There's the one very obvious thing that we don't even need to look for, which is their cause. Is it traumatic or hypoxic? Traumatic, often people have this diffuse axonal injury, or the brain kind of shifts a little bit within that fixed skull. So those attachments of the brain, because they've sheared or shifted, those little axons or kind of arms coming out from the cell body are damaged. Potentially, those things might be easier to regrow and recover versus hypoxic injuries where the cell body dies. And the cell body, if the cell body dies, it can't recover. And so that's one of the mechanisms why hypoxic might have much worse prognosis typically. There's a physical exam finding, and this is relatively new in the sense that it does seem to have some prognostic value. So the physiotherapists can do the PAMS score, which is a physical ability score, 20 items. It should take roughly 30 to 45 minutes, depending on the level of the patient. And one of the subscales is the head control subscale. So lower is worse. So 1 is you have no head control. 5 is you can hold up your head for 1 minute or more. And so they looked at this score at Kennedy Krieger, and they looked at it at rehab admission time as well as 1 month post-admission. So a little bit of a confusing slide. They also intermingled this with their level of consciousness on admission to the rehab center. So I don't know if you can see my mouse, but you can see in the blue is the poor head control people. So you can see poor head control seemed to relate to more people who did not emerge versus otherwise, except for there were still like quite a few people in the emerged group who were MCS plus, or the best of the decreased level of consciousness, who did still emerge. And so for this study, they seem to be sort of similar to us, that they tend to admit DOC patients roughly about 36 days into their injury. And at this center in the States, they stayed, if they did emerge, they stayed a little bit longer, 3 months. If they did not emerge, then 80 days. And it took about 35 days in the rehab center for most people to emerge on average. At 1 month into their rehab admission, that head control became like a much better, not perfect, but much better indicator. So of the people who did not emerge, you can see the large proportion of them had a score of 3 or less at 1 month into their rehab stay, and few of them had a strong score at 1 month. And of those who did emerge, most of them did have this good head control, and few of them didn't. Not a perfect indicator, but some relative prognostic value. Age is also a big thing. So age, even within children who are, I guess, 0 to 18. This study looked at people who were from 2 to 18, and still most people with UWS, 2/3 of them did emerge at 1 year post-injury, and everyone at the center emerged if they started in MCS. And so this is kind of the same data that of the people who had lower level of consciousness or UWS, who at 1 year still had UWS, at their most recent follow-up, that was 2 years or more, still had UWS. So the only difference was in this group, if for this one person who was at 1 year MCS and this person emerged, otherwise no one had changed after the 1 year follow-up mark. There was a study done at the same center in younger children who were 6 months to 5 years. And of these children, none of them with UWS were able to emerge at rehab discharge. And 1/3 of them did emerge from MCS at rehab discharge. And this might be because a lot of these younger children, their etiology, 2/3 of them were non-traumatic etiology. And so they might have other medical problems leading to that as a cause. As well, the other kind of confounder is, as Kate was kind of alluding to, if you're very young, you might not follow commands to begin with because you're a baby or have functional object use. So it's hard because MCS requires you to have these things. So it's hard to know that you are in MCS. So it also confounded by the young age. And so this is from those AAN 2018 guidelines of we should be doing some imaging at 2 months to look at the extent of the lesions. If you have lesions in certain places, this confers a worse prognosis. If you have, if you're more affected, or if you are less affected, you have a better prognosis. The disability rating scale is just a level of your function or impairment. fMRI might be helpful to discern between UWS and MCS, especially if there's clinical challenges as well, like Kate was alluding to. If you have severe motor control issues, you might not be able to do that command, even though you can consciously think of it. So fMRI is not really available clinically, but it has been shown to have a lot of promise in terms of distinguishing between the two. And then EEG or reactive EEG, looking for this P300 is also something that a signal that we see that might be prognostic value. So kind of this is a summary slide, very obvious things. So severity, if you are more severe for a longer amount of time, you're very obviously not likely to improve as well, as fully, or as quickly as someone who is on the other end of the scale. Traumatic injuries have a much more favorable chance of prognosis, and risk of disability gets worse over time as the longer you have this. And there are some very long follow-up data, 10 to 12 years post-injury. For this, they found that of people who they followed up with, many of them did emerge, some of them died. Those who died mostly had some non-traumatic etiology, so maybe had some underlying health issues. And this slide, it's a very confusing looking slide, but this is from very long-term follow-up of adults post-brain injury in the US. And so this just serves to show the different trajectories of illness from 1 year to 10-year follow-up for people who had disorder of consciousness and were admitted to rehab for that. Group 1 is the lowest functioning, so they are low functioning, stay low functioning 10 years later. Group 4, they were very high functioning relatively, and they stay high functioning. Those are no surprise, but these two groups are the interesting ones where group 2 is at 1 year, they're still quite low functioning, but make some good improvements by 10 years. And group 3 is the better functioning and get even better functioning over 10 years. And you'll see here that there's no real drop off or dwindling of these patients. So it's not like some of them died, but other than that, it's not like they have a progressive decline in functioning, especially for these lower functioning people. And so this was an interesting kind of trajectory to know about, that we have this data for, because this group of people would be interesting to know who they are, and because these people might or would benefit from rehab. And so this is kind of similar to what I mentioned before. This study, this is a review of many papers on long-term recovery. And just to say that there are those odd people, rare people that emerge years later, and we've all see them in the news and hear about them. That is not common. And those people who emerge are not magically better. They usually remain very cognitively impaired as well as physically impaired. Although it does happen. Okay. Are you doing the first part? Oh, yeah. So we were looking towards a better or a possible pathway for Sunny Hill to use. And so in Holland, previously, there was this EIN, Early Intensive Neuro Rehab Program, for disorders of consciousness patients up to age 25. And with this program and data, they showed that people seem to have better outcomes compared to before this program existed. And there was a lot of debate in Holland about, why is it only up to age 25? How about all those people who are older, especially with advances in acute care or emergency care, and many people's lives are now being saved from their initial injury, but they are over 25. And people over 25, because they couldn't go to this EIN program, often would go to a care home. In 2019, after much controversy, they decided to create a national program, and it was inclusive of people of all ages. And they had 3 aims or pillars. One of them is assessment of LOC to facilitate recovery. Other aim was to provide care and management of complications. And then the third aim is really about the family or whoever might be assisting in caring with this patient, for education, empowerment, and counseling, all the different things that happen to the family. And they felt it was important that this is a huge pillar of this model. So this is a schematic. Where on the left, you'll see they start in acute care, go to this early intensive rehab, which is 14-week program. It's in one center in the whole country, so everyone with DOC comes to this center. And I'll describe it a little bit more later. And if they do well and they emerge, once they emerge, they go to regular brain injury rehab. If they don't emerge, they might go to this prolonged intensive rehab, which is a care home, which is specialized with people with PIN. So there are several centers across the country there, and they receive about 10 sessions a week of rehab, which is way more than anyone in a usual care home receives here. And after this 2 years, or after they emerge, they might go home or go to palliative care or a conventional nursing home. And through this whole time, they have this mobile expert team. So these are therapists and physicians who are able to assist with diagnosis, therapeutic advice, education, and counseling for the families around things that come up. So this EIN program has nursing care. They have therapy, which is 120 to 150 minutes a day, minimum of 120. So it's 4 or 5 sessions of 30 minutes mixed in with rest. And that's an important thing. Younger kids probably need even more rest, but having those short sessions interspersed with rest is a component. When they are in the UWS state, they focus on a lot of stimulation to see what they respond to. When they're in the MCS state, trying to train these cognitive functions that you're catching or seeing and building on those things. They have weekly rounds and parallel, what they describe as intensive parallel programming for caregivers. So caregivers get their schedule and they have the things that they need to learn and do, as well as at times participate in the therapy sessions that the patient is receiving. For this program, they don't take people who are requiring ventilation, although they can have a trach, and people who require IV medications are not in this program. So we have some early data, which is just captures the first 3 years and of the people and their status at discharge. There's data that they're collecting for 2 years post-discharge as well that we don't yet have. And so there's 104 people who are included in this data. And so this is just the data from the 14 weeks of the program. Kind of a colorful slide, but this gray is the number of people who died. And this bright blue purple is the number of people who emerged. So roughly 45% of people emerge at the end of this program, and the other people are in various states. And after this program, half of them went to a regular nursing home or a specialized nursing home, 38% went to the rehab center, and 6% died. The average time to get into this rehab center was 71 days. So longer. These are people who are not children, they are on average older. And I think because of the IV and ventilation requirement, it might have taken some people longer to get in. So data is supposed to come out this year from their study for their 2-year follow-up, as well as like the outcome on healthcare providers, caregivers, and families.
Just to us a little bit. So talking about development of this pathway, this is just our slide to say we support we appreciate everyone's support and ongoing assistance in like the development of this pathway, all the people in this room, as well as on Zoom. And we welcome any honesty and constructive feedback that you may have. And I made this, so don't judge my PowerPoint skills. But essentially this is kind of the bare model of our proposed pathway. And then they'll have a little bit more details on what we're seeing in rehab on the next slide. So essentially any acute acquired brain injury comes to BC Children's in an acute care capacity. And oftentimes due to the nature of these injuries, they can have various kind of medical courses on acute care. Very often intensive care is involved, and it can take a kind of different amount of time to reach medical stability, which is typically the time we think to transfer to the rehabilitation side and at the Acute Rehabilitation Unit. So at some point, ARU gets consulted, and we aim to assist with not only TBI kind of diagnosis, we also kind of aim to start education and facilitation of moving towards a rehabilitation pathway at that time. And in certain patient cases, we can sometimes initiate shared care within the acute care team, depending on kind of the other comorbidities that are still happening. And essentially, we come to the diagnosis of a pediatric disorders of consciousness. And if it's been longer than 4 weeks, a prolonged disorders of consciousness state. And essentially, we just meet kind of this initial question of emergence, because if you are on acute care for whatever reason for 6, 7, 8 weeks, if there is a time that there's an emergence, we want to consider that you kind of move towards our typical brain injury rehabilitation pathway, which we won't touch on today. Or if you do not emerge within that period of time, you kind of remain within our DOC pathway. So we get involved early on, not only for diagnosis, but also to start those standardized assessments so we can develop and monitor neurological change amidst all of the other medical sequelae. And then when you are medically stable, we love to have people come over to ARU. And so I'll talk a little bit about what that looks like in the next slide. But ultimately, what I'm trying to highlight here is eventually the goal is to transition home or kind of an acceptable alternative location for patients. But we want to emphasize with all the things we talked about that we need to continue to monitor these children. So right now we continue to follow them in an outpatient follow-up capacity, and our goal long-term is probably to incorporate more of these ongoing standardized assessments within the outpatient setting, so we can continue to follow children as they develop. For example, if they were 3, 4, we're going to see developmental change potentially that could change and open up rehabilitation windows that we might consider bringing someone back to ARU or to an outpatient capacity for further rehabilitation assessment. So it's always kind of an ongoing assessment and question of, is there more potential gains here from a rehabilitation capacity? Which brings me to this slide, which is a very oversimplified slide, even though there's lots of text on it. But essentially the goal will be to have a version of this slide that goes towards our interdisciplinary team to support kind of consistent care for these children. And then eventually our goal is to also have a very patient and family forward version of this, so they can follow along the rehabilitation journey and understand kind of the key timelines and pillars that we're looking at. So we kind of break this up a little bit into phases. And this is more so to talk about kind of things as a team we feel need to happen towards the beginning of an admission, and things that we kind of continue to build upon toward within the admission. It's definitely worth noting, though, we don't have intense parallel planning as terminology, but it is all parallel planning. We're already starting for transition care at day 1. So as much as there's potentially phases, it's also worth noting there's a lot of things happening concurrently within the team. So phase 1 is essentially all these initial assessments, and this could even start on the acute side if and when we get involved. So from a medical perspective, we do our initial consultation and we look at that pharmacologic and non-pharmacologic optimization, touching on some of those medications, things like that for kind of neuro optimization. From a multidisciplinary rehabilitation perspective, we utilize our amazing team, and we have kind of a list of standardized assessments to look at different aspects from SLP, PT, OT, REC, sensory preferences, and then we aim to develop goals and a rehabilitation plan from there. And then kind of initial, as all my lovely allied health people in the room would say, you've got to set up equipment day 1, right? Need equipment, so that's kind of the safety piece. And then we aim to plan for an initial team and family meeting within the kind of first 7 to 10 days of admission, so we can really get everyone involved on the same page, including the family, for a successful admission. We move into the next phase, which I have so aptly named rehabilitation, but this is where we continue to grow on those foundations. So continuing education and resources for families, patients, and other people in their lives. And this is when we start to get the systematic data collection from serial assessments. And what that can happen, what that helps with is kind of fine-tuning the rehabilitation plan. So if we're exploring sensory preferences and we realize we're getting more responses from auditory stimulation, we can really kind of weave that in throughout the patient's day. Or if we're kind of initiating amantadine, we can monitor, has there been a change in neurological status with this medication, both positive or negative? And we can make kind of adjustments from that capacity. And then from a transition perspective, we start all the things with kind of collaborative care planning, funding applications, and community supports begin to kind of be engaged at this point. And kind of caregiver and family education to initiate confident patient care upon transition. And then kind of lastly, as we move towards transition, however, that's kind of already been happening, we continue kind of work on those things, and we kind of tie up our discharge assessments for the goal of transitioning to our community providers for ongoing care. And then we also kind of look to transition back into different settings, not just the home, but also school, if that's an appropriate age. And then we really kind of double down on caregiver education, make sure they feel confident. Sometimes we do this by exploring care by parent or care by caregiver trials or a pass home. Those types of things come towards kind of the end of our time together. And then, like we said, we transition to the community and outpatient follow-up, but the goal is not to just see this as, one shot at rehabilitation. We really want to translate this to families, that this is kind of an ongoing thing that we're going to be reevaluating. And sometimes patients do need time, and then we consider bringing them back at another state. Anything else you wanted to add to that? No. I think worth noting, if you're going off the guidelines, it's worth saying that the 2018 guidelines essentially just say that we don't have evidence for a specific therapy for children. I'm getting some smiles back. Thank you so much. But we're pulling from these small studies. We're pulling from adult resources. We're pulling from evidence-based and clinical expertise to try and develop these things. But we're saying it's hard for families to sometimes hear that this is an under kind of studied area. So hopefully there will continue to be things that come out of this and develop over time. Yeah.
And that's it. We just have a thank you slide. We have a cough huddle team. And then if you want to take a picture, like just so for some easy references for the different stages, which can be confusing, but it's important to use the right terminology when you interact with families so that they don't believe they're in a different state than you think they are, and then have different expectations than you. Thank you. And now, yeah, we have some time for questions or discussion.